Good evening, everyone. Welcome to the Weekly Huddle. Today we are 90th session of Weekly Huddle, and I'm very happy that today we are on the 90th session. It's been a long journey. I am Dr. Praneeth Palumuri. I'm a cardiologist working at Care Hospital, Banjara Hills. Today I'm joined with my colleague and co-host, Dr. Anoop Agrawal, who's also a cardiologist working at the same place. We started this program, and on this 90th session, today we are going to discuss about a completely cardiology topic. This topic is something which is dearest to both of us. We wanted to avoid purposefully discussing this topic because it's completely cardiology, but it also looked relevant to us, and we thought we should discuss about this case. Most of you who have joined who already know how the pattern of the weekly huddle works. So I will skip the introduction. We'll start with today's case description. We'll take few opinions and then we equally take comments from others as well. So I will start the case for the today. This patient came to me as an for consultation about 1-2 weeks back. And this guy is a businessman. He is 62-year-old, does not have any significant comorbidities, and he also does not have any significant symptoms that he has. He has his children in Dubai, and so he wanted to plan a trip to Dubai to visit his children. And for his travel to Dubai, he got his routine health checkup done, which was suggested by his physician. And during this routine health checkup, the basic blood workup and ECG echo, which is being done, were done. And then the routine lab work was essentially normal. And the ECG and followed by echo. The most important reason he coming for the consultation is his echo, which was done, showed a bicuspid aortic valve with severe aortic stenosis. The valve area being 0.6 square centimeters. His mean gradient was 56. His peak gradient was 84. Again, for the sake of non-cardiologists who are working or who are in the huddle today, any valve area less than 1 square centimeter is said to be severe. Mean gradient more than 40 is said to be severe. So this patient fit in the criteria of severe aortic stenosis. There are other findings on echo which showed left ventricular hypertrophy, left atrial enlargement, and mild mitral regurgitation. Based on the echo report, he saw a cardiologist, and one cardiologist suggested him to undergo surgical aortic valve replacement. And then he went to a second cardiologist who suggested him to undergo transcatheter aortic valve replacement. He got confused because of these two difference in opinions, and he was kind of having a difficulty making a decision. He was talking to his friends and others, and one of the physician friend of his asked him to meet me to get an opinion and discuss about the treatment options. So this patient, who is 62-year-old male, who has been asymptomatic, who got incidentally detected to be having severe aortic stenosis, what would be his treatment options are the topic of discussion today. So the discussion points that are pertinent, which I thought were: first, can lack of reported symptoms as by this patient should be considered, and should we take these patients as asymptomatic severe aortic stenosis? What are the options of the so-called medical management for aortic stenosis if we have to give them? And if these patients have to be suggested an aortic valve replacement, what is the optimal timing? When is it the optimal timing? Are we too early or are we too late? And if we have to offer them aortic valve replacement, when should the patient go for surgical aortic valve replacement? When should this patient go for transcatheter aortic valve replacements? So these are the questions. I will pick up a few of the members in the group, and then I'll come to Anup at the end because he is an expert himself in this field. So I'll pick some names. I'll start with Dr. Patrick Sardi. Patrick Sardi is a junior consultant who joined us recently. Patrick Sardi, you heard the story or the clinical summary. If this patient has come to you, what do you think you would be advising these patients? And is there any other relevant questions that you would like to answer? I will try to share. Patrick Sardi, how would you take up this case? Patrick Sardi, are you able to hear me?
Partho, you'll have to unmute yourself first before you speak. Yeah, just unmute yourself. We can see that you have raised hand. Please unmute yourself.
Okay, there seems to be some problem with Patrick Sardi, I believe. I'll take opinion from Praveen. Praveen, if this case has come to you, what do you think you would suggest him? Like the 4 questions that I have answered, are these patients not having symptoms? Should we truly consider them to be having asymptomatic aortic stenosis, and the other questions that I have? So if you can answer one question at a time, what I have put forward.
Good evening, everyone. Good evening, sir. Coming to this case, if the same patient comes to me and the patient shows the echo report of aortic valve area of 0.6 centimeter square, and patient then is just that he does not have any symptoms, I would just go back a few years ago, what he was doing and what he was not doing now. Because as classically said in the valvular heart disease of the stenotic lesions, most of the time it is the low cardiac output, so they curtail their activities and just they accustom to their restrictions and they lead as a life compared to that of the regurgitant lesions where they have the usual symptoms. So say for example, the same patient was doing all his activities, the physical activity, which is very much, and now he has restricted his physical activity, but reasonably doing good. Then I would consider it to be having a symptomatic, sir. And the next thing I would see is if the patient still denies that the physical activity, whatever is there before, I am doing now also, and he's not giving any clues of restricted physical activity. The next thing to mend for the further management, I would be doing a CT scan of the whole of the aorta to see the CT calcium score. And in the echo report, I would do myself and see for the stroke volume and take further decision. Hello, sir.
Yeah, Praveen. Thank you.
Sir, sorry to say, I did not hear the other questions, sir.
Yeah, so the other questions to answer is, what do you think is the option of medical management for aortic stenosis?
Medical management for aortic stenosis, I would say if patient is having an LV dysfunction and patient to what you call to bridge the therapy for the TAVR or SAVR, I would go for the medical management. Otherwise, if patient is fit and there are no hurdles for SAVR or TAVR, I would directly take, sir. Rather than that, there would be no medical management. As far as I think, if patient is having a high gradient, then if patient is asymptomatic, I would do the stress test or the so-called the risk stratification by CT calcium score, and then keep the patient for TAVR. Otherwise, I would not do anything for the medical management, sir. If patient is having LV dysfunction and patient is not in a suitable condition to take for then I would do a BAV and then keep the medical management. That would be an AC.
Yeah, and when do you think is the what do you think is the optimal timing for sending this patient for an aortic valve replacement?
Considering this patient and the gradients being high, I would counsel him for as early as possible, sir, because the recent review articles have shown that even if patient is having an asymptomatic severe aortic stenosis, if the flow velocity is more than 5 and the mean being more than 60, that itself is a class 1 indication. So I would not wait him, because we at that stage when we already know the patient is having severe AAS, even if patient being asymptomatic, it is better to avoid an event which can be prevented by an early surgery or a TAVR.
And what should be the treatment option, SAVR versus TAVR?
SAVR versus TAVR, sir. If patient is at low risk, I would still prefer SAVR only, and intermediate risk and high risk, I would go for the TAVR. But if patient is not having any comorbidities, he is low risk, I would prefer SAVR over TAVR.
So what do you think this patient will fall into? Will he fall into which risk category?
Sir, before considering this patient risk category, as you said in the history that the patient, he is not looking after his business. Most of the time it is being looked by the son. And he is considering his physical activity, I would be considering the frailty index or the dependability. Of course, for 62 years, probably he might be doing all his activities on his own. If that frailty index is not that much, is what you call good, I would go for SAVR. And if it is very less, I would consider the TAVR. The option of SAVR versus TAVR would be that if patient, even though he is having an intermediate risk, the age would be making a criteria. Why? Because still we don't have the durability of the TAVR for more than 10 years. Of course, the trial recently 10 years data has been shown, but considering SAVR would be better. After the risk stratification, considering his age, if he is good fit, then it would be better to consider SAVR, because the durability of the valves are more. If the same patient is not having any comorbidities and is of 70 years of age, I would consider TAVR.
Yeah, so this person who is a businessman by profession does his normal 30-45 minutes of morning walk. Rest of the time, he's not much physically activities. He travels by his car to his office, gets the job done, and comes back home. And whatever daily chores that he was doing, he was able to do previously as well. So he could not appreciate there is any significant reduction in his physical activities or physical capacity. So in that way, he considers completely asymptomatic. And he's well built. He is definitely not frail, and he is physically active. So he does not belong to any sort of frailty. And as said, no matter how many times I asked questions, he really did not have any symptoms that he could share. So with whatever information that you have, if I understand correctly, for this patient, you consider him to be having low risk, and you would recommend surgical aortic valve replacement, if I understand correctly, Praveen. Yeah, I think we lost Praveen. I think.
Hello, sir. I would consider SAVR, sir.
Yeah, sure. Thank you. Thank you. Got
okay.
it. Patrick Sardi, are you able to share your comments?
Yes, sir.
Yeah.
Actually, sir, the patient is limiting his activities. So we don't know his exercise capacity, because he's not doing his previous routine activities and is limiting his activities. In this patient also, we can't do any TM2 to determine his exercise tolerance and everything. Considering his age, the ideal would be the SAVR, sir, because in this patient, the long term, he's having still the 62 years only. So the durability of the TAVR wall will be up to 10 years only. So I consider TAVR in this patient.
So his physical activity per se was very limited, and as I was mentioning, about 30 to 45 minutes of daily walk, and rest of the time he's very limited going to his office and coming back home. So there is no limitation of physical activity that he reports. And I hear what you are saying, that you also opine this patient to go for surgical aortic valve replacement.
Yes, sir.
I would take one more opinion before I come to Anoop. I would take opinion of Shankar sir. Shankar sir, you are a physician. Most of the patients, they piggyback on the opinion of their physician whom they are following for quite some time. If this patient was following you and if he seeks for your opinion as helping in making a decision, what would you suggest this patient, sir? How do you think you will approach this case, and what would be your take on this patient?
Good evening to all. Congratulations on the eve of 90th session of Weekly Huddle. See, as a physician, we come across cases of AV sclerosis, mild, moderate, severe aortic stenosis, and ultimately we send them for, in severe cases, whether it is asymptomatic, asymptomatic, we send them for evaluation for TAVR or TAVR, surgical aortic valve replacement or transcatheter. So here, this patient is having bicuspid valve. So bicuspid aortic stenosis with bicuspid valve. The etiology of aortic stenosis is congenital bicuspid, then degenerative or calcific aortic stenosis, and the rheumatic. Most of the times we come across. The rheumatic almost that is waning down. So here this patient is having bicuspid, congenital bicuspid valve. Though it is a congenital, but most of the time the calcification and the degeneration of the bicuspid valve occurs after the 50 years of age. So they manifest after 50 years of age only. So here the patient has got a severe aortic stenosis, and looking at his the aortic valve area less than 0.6 centimeter square, and his peak the mean gradient is more than 60. So it comes under actually super severe or very severe AS. So he claims that he is asymptomatic, but on 6-minute walk test or exercise treadmill test, ETT, we can come to know, suppose if he has got a decreased exercise tolerance or exercise capacity, or usually with the exercise the BP rises, but here if the BP falls more than 10 millimeter of mercury with the exercise treadmill test, that goes in favor of almost a symptomatic AS only, a severe critical AS. Then let us go for the, suppose if there is a myocardial involvement is there, then we go for biomarkers like BNP or NTP, pro-BNP. If it is more than 550 picograms per ml with the BNP or NT-pro-BNP, if it is 3 times the normal, that is also very significant. And 1/3 to 1/2 of the patients with the aortic stenosis will have coronary artery disease. So we have to evaluate for that. We should go for coronary angiogram, either CT or invasive coronary angiogram should be done to see that any CAD associated or not. And if left ventricular ejection fraction is less than 50%, that is also a critical one. And if there is a rapid progression of the valve aortic stenosis by means of, say, if the peak aortic jet velocity, if it is more than 0.3 meters per second, or peak mean gradient, if it is 4 to 7 millimeter of mercury, or the aortic valve area increases per year. All these things, parameters are per year. 0.1 centimeter square per year, a peak gradient 4 to 7 millimeter per year, or the aortic jet velocity, if it increases at the rate of more than 0.3 meters per second, then that is indicative of a rapid progression of the disease. And one more thing, everybody does it, that is a dopamine stress echo. If it is, we can know that the contractile reserve is there or not. There is increase in the 20% stroke volume index, or a peak that is a transaortic pressure gradient more than 10 millimeter mercury, that indicates that there is a contractile reserve. So these are all the 7 parameters. When the patient comes with the asymptomatic AS, we should find out whether it is a critical aortic stenosis to undergo surgery or not, a TAVR or SAVR. So here the patient has got a bicuspid valve. Most of the times the bicuspid aortic valve will be associated with the dilated ascending aorta, because there is a defect in the media of the aortic root. And also in the bicuspid valve, most of the times, if you see the hemodynamics, the eccentric jet that causes, there will be dilated aortic root. So aortic root is essential, because aortic root in the TAVR, the dilated aortic root is a little difficult to place the valve. So here I go for surgical aortic valve replacement. If the patient agrees for vitamin K antagonist anticoagulation, then I will go for the mechanical valve, prosthetic valve, because he comes under the age of less than 65 years of age. A mechanical prosthetic valve is an ideal one in this case. So, but results of Dr. TAVRologist is there very much with us, Dr. Anoop Agrawal. He will enlighten, because this is what I, with my knowledge, little knowledge, I say that I go for SAVR, that is a surgical aortic valve replacement, looking at his age, low risk, low surgical risk, and most of the times the dilated aorta will be associated with the bicuspid valve. So I go for SAVR, that is a surgical aortic valve replacement. The results of TAVR in the patients with the bicuspid aortic valve, as opposed to tricuspid, they have been very less impressive. Probably Dr. Anoop Agrawal agrees with me. So newer modifications might have come, that will be enlightened by Dr. Anoop, might have come to improve the success rates. So if we go for the prosthetic valve now, because the patient has got life expectancy more than 20 years. So I prefer to go for prosthetic valve. So if he is not desirous of vitamin K anticoagulation, or if it is not well managed, INR or other parameters, then we can go for the bioprosthetic valve. So if in the long run, if there is a chance, there is a room for TAVR, because the valve in valve, this is already discussed earlier. So in case of prosthetic valve dysfunction, we can go for a TAVR at a later date. So at present, I prefer to go for SAVR, that is surgical aortic valve replacement. And if the patient can afford, then if the patient is not desirous of taking vitamin K antagonist anticoagulation problems at all, because the drug interactions and interactions with the leafy vegetables and all. So we can go for bioprosthetic valve for a short-term anticoagulation, and later the patient can be on aspirin or clopidogrel. Thank you.
Yeah, thank you, sir. I hear what you're saying. Anoop, before I come, I would also want to take opinion of Vijay Reddy, sir. Sir, Vijay Kumar Reddy, sir, I want you to answer the 4 questions which I posted. And I also have a specific question for you that how frequently do you order any exercise stress testing or any other form of stress testing in a patient who has asymptomatic severe aortic stenosis in this patient? Over to you, sir.
Okay. Good evening, everybody. So here the issues are 3. Number 1, patient is a 62-year-old gentleman. He is bicuspid aortic valve. He is asymptomatic status. And before that, we should assess the symptomatic status, whether the patient is truly asymptomatic or hiding some symptoms. So the treatment options, whether to go for TAVR or SAVR, the American Heart Association, the age criteria is more than 65 and European guidelines says more than 70 years. That is number 1, though this patient is only 62 years. And usually asymptomatic patients, usually we don't advise a TAVR. And in this patient, I will advise this Dopamine stress, all those things in a low pressure is not in a normal LV function patients, because already we know the this thing severity of the aortic stenosis. The pressure patient is having low pressure, low flow gradient, then we'll advise to assess the severity. That is number 2. Number 3, I advise I will go for a surgical aortic valve replacement, preferably a bicuspid with bioprosthetic valve because of the low STS score, and which will last for nearly more than a decade. Even if there is a bioprosthetic valve dysfunction, we can put valve in valve as advised by, as rightly pointed out by Dr. Shankar. So I prefer a SAVR rather than TAVR in a 62-year-old gentleman. That is my take.
Thank you, sir. So, Anoop, I'll come to you. Shankar sir used a nice term, TAVRologist. So, Anoop, your take on this patient, and I have specific questions for you. Praveen mentioned about doing CT calcium score of the aortic valve. For a patient who has the diagnosis established as per the criteria, what do you think there is this role of CT calcium score? Do you think there will be of any use, or will it help, or is there? What do you think CT calcium score of the valve in this patient?
Okay, so Praneeth, thank you for bringing this topic, and I just want to highlight to the audience why we are talking about it. I remember when we started doing Huddle, we promised ourselves that we are not going to talk about anything which is very, very restricted to a subset of doctors, which in this case are structural interventional cardiologists, and not just interventional cardiologists. So this is as specialized as it's going to get. And while we are part of that in our daily work, we thought this kind of topics don't belong in the weekly huddle discussion. But I just want to highlight the rationale of putting this case in today's discussion is the decision making regarding which way to go, particularly because patients would be coming to cardiologists and physicians with these discrepant decisions. And that is where I think we need to hold the fort to make sure we guide our patients for the correct therapy. So Praneeth, this is a topic that I deal with, and I can go on for hours. So I'll try to restrict myself, and I'll try to answer a specific question that comes along. I'll quickly go through the discussion points mentioned, and I will also go through the topics which have been discussed so far. So lack of reported symptoms to be construed as asymptomatic. This is actually a very, very debatable topic. Praveen very nicely mentioned that people, they tend to slow down because of their low cardiac output status. And I actually went so far ahead as saying that there is nothing called asymptomatic severe aortic stenosis, because when you start taking history and when you start putting them on treadmill, you realize that almost 75% of those patients, they end up either having symptoms or they end up failing treadmill test. So now we are talking about 3 out of 4 patients getting into the criteria of requiring AVR. So we probably are labeling patients asymptomatic more than what we should be doing. You mentioned about medical management of aortic stenosis. There was data set with statin therapy that did not show any benefit. There is some thought about ACE inhibitors trying to at least halt or reduce the progression of disease. The data is not very clear, but that's what cardiologists like us end up doing. But truly speaking, there is no proven medical management for aortic stenosis. Optimal timing for aortic valve replacement, when is too early, when is too late, and this is a very difficult thing. If a person is obviously symptomatic, then we should definitely do it. There is no point waiting. But if a person like this who is asymptomatic, there we have to figure out when are we offering therapy too early in the course of the disease. And there are certain risk parameters that we look at. But what I would try to emphasize more and more is that we need to spend time looking at the history of these patients. A lot of these patients, like in this particular case, the fact that he slowed down in his business, to me, that's a red flag. Many of the patients, they stop going to their morning walk. Many of the patients, they hire house help. These are soft things. They are very, very soft things, but you end up knowing that they have slowed down. So that is very, very important. Surgical AVR versus TAVR, there has been multiple points which have already been discussed today. Age as a cutoff that Dr. Vijay sir mentioned, I will tell you. So sir, European guideline actually has a cutoff of 75 and US guideline has a cutoff of 65. And while these are cutoff, they are not hard cutoffs. They don't say that every person beyond 65 should get TAVR. What they're saying is age less than 65, you probably shouldn't put TAVR on them. So, but in Indian subset, where the longevity of a typical Indian person is not as much as their Caucasian counterpart, we need to have our own age cutoff. And the reason why the age cutoff of 65 and 75 came in US and European population is to do with their longevity. And what we want to make sure is that if a patient who has got more than 15-20 years of longevity, then we probably should not be offering them TAVR because we don't know the long-term durability of these valves. Having said that, 2 points that also were brought up in today's discussion. One is offering mechanical aortic valve at the age of 62. I don't think that a lot of surgeons would agree to that. Before the era of TAVR, age less than 60 was one of the criteria to offer mechanical valves. And age more than 60, definitely surgeons universally gave bioprosthetic valve. In the era of TAVR, that age has become now 50 or 55. And the reason why is because now a degenerated bioprosthesis is much easier to deal with just by putting a TAVR inside a bioprosthetic valve. So certainly that threshold has got better or changed. So we will see more and more middle-aged adults getting bioprosthetic valve now correctly as compared to what we were seeing previously. And then the mention of TAVR valve having lesser longevity as compared to surgical valve, I don't think that's a established fact. In fact, a lot of early signals would actually suggest that the TAVR bioprosthetic valve is more likely to have better longevity than a surgical bioprosthetic valve. And there are various reasons for it. It has to do with hemodynamics. It has to do with the effective orifice area of TAVR bioprosthetic valve is typically better. and also the hemodynamic currents that TAVR valve generates is actually favorable for a long-term outcome as compared to surgical valve. So while the hard data is not there, if you go by the early signal, one would suggest that the TAVR bioprosthetic valve is poised to either match surgical valve or it may actually outperform surgical bioprosthetic valve. That data we don't have it yet. So to decide between TAVR and surgery, one has to take age into account, but one also has to take the overall longevity into account. And if longevity is more than 15-20 years, then the guidelines so far would suggest that we should go for surgical valve as compared to TAVR valve. The another issue with bicuspid valve particularly, and that was also mentioned by Shankar sir, one was aortopathy. That is very relevant because a lot of these patients, they have ascending aortic aneurysm, which is not particularly picked up by routine transthoracic echo. And all of these patients, they should get a basic CT scan or a extended echo or a transesophageal echo to look for aortopathy, which if present, then that's a very strong indicator of sending these patients for surgery as compared to TAVR, even if they fit as a TAVR criteria patient. Then another point that was brought up is the TAVR efficacy in bicuspid versus tricuspid. In fact, that was a question which was raised about 5-7 years ago. But currently we have enough data to actually show that using the newer generation valves, the overall valve performance in bicuspid valve as compared to tricuspid valve is more or less the same. Bicuspid aortic valve is associated with a longer procedure time, a higher requirement of pre and post dilatation, but overall they do not have any higher procedural complications, and their long-term outcomes are actually pretty good. So at this point of time, I wouldn't discount TAVR just because it's a bicuspid valve. In fact, it is important to note that almost 40% of the Indian population who gets TAVR have a bicuspid aortic valve. And the Indian data set so far actually looks very good. So those were the two important aspects about the bicuspid valve. There was some mention about stress testing. I would highly caution, please do a stress testing only and only you have explicitly taken a history and diagnosed that this patient is truly asymptomatic. And I can assure you, to get that kind of history takes about minimum 10-15 minutes. You cannot take a history in 2-3 minutes and declare a patient asymptomatic. Because if you put a symptomatic patient on treadmill, then there is a very high risk of a hypotensive response, which sometimes can go into a death spiral, and it is very difficult to get patients out of that. So if you intend to put a patient on treadmill, it has to be a physician supervised. It has to be a very intricately performed procedure by a center who routinely does a lot of TMT. And it has to be in a patient who is truly asymptomatic. Exercise echo in severe AS to identify the candidacy for surgery in asymptomatic patient is reasonable. It is not well validated, but it is reasonable. But doing a dopamine echo in asymptomatic patient to define whether this patient should go for surgery or not, that is not validated at all. So I do not think at this point of time dopamine echo can be used as a surrogate to identify which patient should go for surgery. As Dr. Vijay said, that if you have a low flow, low gradient, then to diagnose severe AS, dopamine echo has a standard role. But a person who already has a diagnosis of severe AS, who is asymptomatic, you want to identify whether they should go for surgery or not. Doing dopamine echo at this time is absolutely not validated at all. And Praneeth, I'll come to your question last, that is CT scan or a calcium score to identify which patient should go for surgery. So, aortic calcium score has got significant correlation with aortic stenosis. The higher the calcium score, more is the likelihood of a patient having severe AS, which means if you have a diagnostic dilemma, whether the patient has severe AS or not, and echo is not helping you, There you can do a CT calcium score, and if CT calcium score is beyond a cutoff, those cutoffs are defined separately, but a commonly used term, a commonly used number is 2000 for males and 1200 for females. If aortic valve calcium is more than this cutoff and there is an equivocal echo finding, then the chances are you are dealing with severe AS, because higher the calcium score, higher is the likelihood of severe AS. What is also shown is higher the calcium score, poorer is the clinical outcome, which means if you have a asymptomatic severe AS patient and they have a higher calcium score like 3000, 4000 or whatever, then you would expect them to have worse outcome as compared to somebody who has a 2000 or 2100 calcium score. Having said that, utility or clinical utility of aortic valve calcium score in making such decision to send a patient for surgery, that has not been validated yet. So there are a lot of trials which actually support this notion that higher calcium score means poorer outcome. And even in asymptomatic patient, one can argue that these patients should go for early surgery. There is hypothesis advocated for it, but in the clinical practice that has not been tested yet. So at this point of time, I would suggest that limit calcium scoring only for diagnosis of severe AS in cases where you have equivocal diagnosis. But in those cases who already have a severe AS diagnosis, using calcium score to decide whether a patient should go for early surgery or not, currently that is not validated, and I wouldn't recommend doing that. Praveen asks about the use of Frailty score in TAVR. So Praveen, Frailty score is associated, has been studied quite significantly in the TAVR subset. What we know very clearly is that patients who are frail, they do very poorly with surgery. And patients who are extremely frail, they do very bad with TAVR as well. So we use Frailty index to identify those patients who are a little bit frail, that TAVR will be better for them, or TAVR will be able to alleviate their symptom and make them feel better. But when we have those patients who are very frail, in those patients, we should question whether TAVR should be done or not, because their overall longevity will be decided by their frailty, not by their severe aortic stenosis. And there are common frailty scores. The most common which is being used combines 4 clinical points which are easy to do. One is hemoglobin level, one is albumin level, and 6-minute walk test, and you have got a hand grip or whatnot. So lot of these, what we call it as a get up and go test, where you make them get up and then walk around. So lot of these scoring algorithms are there, and if a person has got all 4 or all 5 deranged, then those patients you can counsel beforehand that their chances of doing much better with TAVR also is less, because they tend not to do very well. Those patients who only have 1 or 2 frailty points, they should be taken for TAVR. Those patients who have no frailty point, and if they don't meet the other criteria for TAVR, they should go for surgery. So in this particular patient, Praneeth, whether this patient should go for aortic valve replacement now or not, I think he should. I think the symptoms here are underplayed. He should go for aortic valve replacement. Whether he should go for surgery versus TAVR, and this is the critical point for which today's discussion is in place. In a 62-year-old guy, otherwise healthy, we should not offer TAVR on him. We should offer surgery on him. The whole rationale why TAVR came for this patient subset was, you do a TAVR now, and then after 10, 12 years or 15 years, when the valve degenerate, you do a TAVR in TAVR. So TAV in TAV is going to give you 20 years or 25 years, more or less. That is a reasonable argument to make in patients who are otherwise healthy, but are beyond 65 or 70 or whatnot. But a person who is 60, 62 and very healthy, they can very well outlive a TAV in TAV. They can very well outlive the second valve as well. Then you won't have any other option to put a third valve in there. That becomes very, very challenging. So in these patient subset, you do a surgical bioprosthesis. When that valve degenerates, you put a TAV inside a SAV or a TAVR inside a SAVR, And when that TAVR also degenerates, you can put a tab inside a tab inside a SAV. These things are more logical than putting a third TAVR valve in a person who already got two valves. I think that is not a very reasonable way to go. So in younger individuals who desire not to get anticoagulation, or those individuals who are beyond 60, who are healthy, going for a bioprosthetic surgical valve seems more logical than going for a TAVR. And that is the point that I think we want to highlight in today's discussion, that unless there is a high risk feature or an intermediate risk feature for that matter, we should not be offering TAVR to these kind of patient subset. They should go for surgery. And one last trivia that I would tell, which a lot of you already know, that the longevity of bioprosthetic valve is also dependent upon age of the recipient. So younger the recipient, shorter is the longevity of bioprosthetic valve. Older is the recipient, longer is the longevity of the valve. So at 62, you do expect that these valves will last for more than 10 years. And then if you put a TAVR valve inside it, that should pretty much match a person's life expectancy. On the other hand, if you put it in a 50-year-old, that valve may degenerate in less than 10 years. And now you'll be chasing your own tail and you won't be able to get a good answer. So Praneeth, I hope I was able to get some of the ideas through it. And if there is any particular question, then I can answer that.
Yeah, you answered most of the questions which I had a note. The two follow-up questions is from the patient point of view, who says that I'm doing absolutely fine. How would you convince this patient to undergo valve replacement? Like, how do you say that you deserve valve replacement?
Right. So one very simple way I do it is I ask them to look at their age-matched peers, so their friends, their family members, and then I ask them, what are you not able to do that other people are able to do? And many of the times they blame it on their aging. They're like, no, I'm 70 years, I'm 65 years, it is my age. So many of the times that gets the ball rolling. The other is what Praveen mentioned, that you ask them, what were you doing 6 months ago or 1 year ago? Remember, these histories are not taken over days, they are taken over months or maybe a year. So you ask them, what were you doing last year? A very common answer this time I'm getting is, I don't go for morning walk because it's a COVID and I don't want to do that. In essence, they are not going out not because of COVID, they are not going out because they are getting tired easily. For those patients on whom history does not lead anywhere and the patient is convinced that he is truly asymptomatic, putting those patients on treadmill under my supervision or under we have excellent NI lab is not a bad idea. So those will be the patients I'll put them on treadmill.
Okay. So considering his age and his low risk, we believe transcatheter valve replacement is out. But as Shankar sir has suggested, going for a surgical valve replacement with a mechanical valve. What do you think is the problem with mechanical valve? And why should this patient prefer bioprosthetic in your opinion?
So Praneeth, at 62, if you do mechanical valve, here are the problem. It is very difficult to maintain a therapeutic INR at this age group. That is number one. Number two, remember, this is the age group which require more interventions as the age, minor procedures or major procedures or whatnot. It is very difficult to manage anticoagulation, even if they require something like an endoscopy or if they require a simple angiogram or whatnot. That becomes more complicated. And truly speaking, bioprosthetic valve these days, they have become very good. At age 62, you expect them to last for more than 10 years. And when they fail, doing a TAVR inside a bioprosthetic is very simple, very straightforward procedure. So gone are the days where you do a bioprosthetic, if it degenerates, now you are dealing with a redo surgery at age of 70, which was a concern. But these days, that is not a concern anymore. You can simply just do a TAV inside a SAV. It's a simple procedure to do that will give them another 15 years. So you're talking about now somewhere between 20 to 30 years of life expectancy for the valve. That is pretty good for a 62-year-old guy. You are pretty much giving him a game plan for his 80 to 90 years of age that I think it quite reasonable.
Yeah, thanks Anoop. So the whole rationale, as you mentioned, the discussion of talking about a core cardiology topic is that as a physician, we should be in a position to make decisions. So you need not be a cardiologist to treat coronary artery disease or do transcatheter valve replacement. I heard from Dr. Somaraju sir, who used to say that as a physician, you should be in a position to look at angiograms and interpret them. You may not be good in doing interventions, but at least you should be having the information to make a decision for your patient. So I think in this regard, I believe that as a physician on whom most of the patient rely a lot on making a decision, so physician should also be in a position to understand how a decision making is done, and they should be in a position to contribute to the decision making. So hence we chose this topic. Somraj sir, I would like to take your comments on what do you think should be your approach on this patient, and anything that we missed in this discussion so far.
Thank you, Praneeth and Anoop. I'll only highlight one or two issues. Number one, we came a long way in managing aortic stenosis from 1960s to now, where there was a famous statement all of us knew what Professor Braunwald said in 1960s, where he said the commonest cause of death in asymptomatic severe aortic stenosis is surgery. And from that time onward, we came a long way. Surgery has become safer. And also TAVR has taken over a lot of things that surgery cannot do, or even do better in certain of the high-risk groups, etc. Having said that, I just want to highlight one or two issues. Taking shelter under symptoms, where each human being reacts differently for the same stimulus, whether it is an infection or structural heart disease or anything, to defend upon symptoms is taking shelter under uncertainty, where you didn't have enough methods of evaluation, enough technology to be able to reach a correct and accurate diagnosis, both presence or absence of disease and severity of disease. We have come a long way there, where we can accurately assess severity of the disease. To try to depend on symptoms now, I'll just highlight one issue. There is evidence that symptomatic severe aortic stenosis, there's a chance of sudden death in the next 1.5 to 2 years, so that all of us are aware. But mind you, there is no evidence, nobody has studied this enough, that severe aortic stenosis, asymptomatic, doesn't result in sudden death. So we are still depending on going on talking about 1960s language. When you go on talking about symptoms, that is very disturbing to me, and you have to reassess. The whole cardiology has to learn to reassess these things. And I will also add only one more issue, namely severe aortic stenosis with this type of gradient with the LVH concentric. To try to do dopamine echocardiography is dangerous. It's contraindicated. Not that there's no data on it. It's contraindicated. It should not be done. And they'll have suicidal left ventricle and die. And also even I would treadmill testing. Treadmill testing, symptoms during treadmill testing is not the same thing as exercise in real life. And also treadmill testing in a severe aortic stenosis of this degree is also potentially dangerous. I'll leave it at this. Many other issues are already brought out by most of you. Thank you.
Yeah, thank you, sir. Point well taken that exercise stress testing in any form, be it a treadmill or dopamine, is a really scary thing, and we should avoid it as much as we can. Anoop already mentioned about the calcium scoring of the aortic valve, which is non-invasive, and probably that helps making a decision when in doubt for those patients who are asymptomatic severe aortic stenosis. But point well taken, sir. I think we are close to 8. Is there any questions regarding this topic from anyone? We would be happy to take it. While you are gathering your thoughts, Anoop, you can probably sum up about the issue of aortic stenosis, on what are the take-home messages on what to do, when to refer, and how to make a decision making.
So Praneeth, Somaraju sir mentioned about the perils of doing stress test in severe AS. And you know, while we have a cutoff of 4 meters per second as severe AS, remember, even 4 meters per second is severe AS, even 5 meters per second is severe AS, even 6 meters per second is severe AS. There are certain grading of calling it critical or very severe or whatnot. But the point that I'm trying to make is that it's a continuum. So there are certain things which, there are certain way you think when the velocity is 4, but your thought changes when the velocity is 4.5 or 5 or 5.5. Now you are dealing with, now you are in the territory where it is very, very high risk. There was a very recent data set which took patients with a velocity of more than 4.5 and did empiric surgery on them, even after properly excluding or properly including only those patients who were asymptomatic, truly asymptomatic. And there also they proved that doing early surgery in those patients subset actually saves more lives than just watchful waiting. The whole concept of watchful waiting is waning. And I want to quote the phrase that Somaraju sir said, that we should not take a shelter under this so-called lack of symptom scenario, because many of the times they are masked, many of the times we don't know what we are dealing with. These days we have a lot of tools. There are blood tests which can mark. There are a good historical data set. That's pretty much about it. You sometimes may not even need to do multiple tests that can help you unmask those symptoms. But the take-home message that I want people to take with this is, these days we are not talking about treatment of aortic stenosis. We are talking about lifetime management of aortic stenosis. So what we are talking about is, if a person has got aortic stenosis that you have diagnosed now, that you think should be treated, how are you going to manage this aortic disease, aortic valve disease, for the patient's lifetime? Not just fixing it now and saying I'm done for next 10 years. You're talking about a lifetime management, which means you also need to look at their potential need for coronary angioplasty in the future. You also have to look at whether they have concomitant valvular disease in the future. You have to look at what kind of aortic wall pathology they have. You have to look at what happens if you put a certain kind of bioprosthetic valve now. What do you do in the future for that? So it all is changing, it's shifting gears towards so-called lifetime management of aortic stenosis. This is where mechanical valves miserably fail. Because while a mechanical valve at age 50 is a very good idea, the same mechanical valve at the age of 65 and 70 is going to be a major morbidity in that person's life. Now that person cannot do even a simple procedure. Any simple procedure becomes a high risk procedure for that particular patient. Even cataract surgery, for that matter, entails all these kind of risks. Even a simple dental procedure becomes a severe risk for them, just because now there is a mechanical valve sitting there. So the lifetime management of aortic stenosis involves not just treating the problem at that particular point of time, but also looking at what happens in the future. And this is where sometimes you see TAVR being done in age 55, 57. Well, at that point of time, the procedure is done very nicely. You got a very excellent result. But the real problem will start after 8, 10 years or 12 years or so. So in those patients, we have not done a good lifetime management of severe aortic stenosis. So in these cases, like the index case that we are dealing with, when we go in that terms, we should be offering, or we should be talking about surgery. Even if a patient is reluctant towards surgery, we should be discussing with them, counseling with them, and telling them that, you know, surgery is probably the best course of action right now, even when TAVR seems to be a very simple, straightforward, minimally invasive procedure. And, you know, we as cardiologists, we are conflicted, right? We have that conflict of interest because we are the operators for TAVR versus surgeon is the operator for surgery. But we should recognize our biases. We should recognize our conflicts and make the decision which is right for the patient. So I think that should be the take-home message, that TAVR is not for everybody, and we should be selecting patients correctly so that we give them a lifetime treatment of aortic stenosis.
Yeah, thanks, Anoop. So for this patient who came to me, the same points were discussed. The whole point of surgical versus transcatheter valve replacement were discussed. And I offered him to undergo a surgical aortic valve replacement with a bioprosthetic valve. I also told him the options of mini sternotomy, which is being done commonly now by the surgeons, because surgeons have also increased or improvised the surgical skills, where without a complete sternotomy makes the post-operative outcomes even better. So I suggested him to go for surgical aortic valve replacement with a bioprosthetic valve, preferably by a surgeon who is comfortable doing it with mini sternotomy. So that was the discussion about today's huddle. If there are no more questions or comments, probably we can. I think Shankar sir has a.
Shankar sir has something. Yeah.
Shankar sir.
Regarding the medical therapy, if the patient is with the patient of aortic stenosis having associated hypertension, it should be treated. We should start low and go slow. And the statins, if a patient has got ASCVD, statins for the prevention of primary and secondary, but not in the prevention of progression of the AS. And RAS blockers, as already mentioned, these ACE inhibitors or ARBs, in patients who have undergone TAVR, it may be considered to reduce the long-term risk of all-cause mortality. But I want to know, last question. See, earlier we used to read that biphosphonates, they inhibit the cholesterol synthesis pathway, resulting in several anti-atherosclerotic pleiotropic effects, and it also inhibits bone resorption, may indirectly reduce the calcification of the cardiovascular tissues. Biphosphonates, especially the nitrogen-containing biphosphonates, earlier we used to give, but I read somewhere, but whether is it the practice or not, just I want to know from Dr. Anoop Agrawal.
Sir, I don't think that so far we have any evidence that any medication helps us reduce the progression of aortic stenosis or calcification there. Our knowledge is certainly evolving. Now we know better that the calcification at the aortic valve is not an age degenerative process purely. It does have inflammatory component. There is an active cellular mechanism that is happening there. It is a form of dystrophic calcification that we are learning more. But so far we have not found a therapeutic target that actually is going to help. In fact, recently there was a thought process that whether reducing LP lipoprotein A, whether that can reduce the progression of aortic stenosis. In fact, the recent data set that actually looked at correlation between BMI and lipoprotein A and aortic stenosis progression. And what they found is, if a person has got higher BMI, then the aortic stenosis progresses almost 1.8 times higher. And if a patient has got lipoprotein A high, very high, we are talking about numbers more than 60 or 80, with a normal being less than 35. So there also the progression is increased by 1.7, 1.8 times. And those patients who have both, who have high BMI and who also have higher lipoprotein A, they are almost 3.5 times higher likely of progressing AS. So we are learning that there is certainly some inflammatory markers that that can be contributed towards AS progression. Now the second level of study that will be pertinent is using PCSK9 inhibitors to reduce that lipoprotein A and to see whether that has got any effect in AS progression. But so far we don't have any conclusive data set. So far we don't have any therapeutic target, and right now ACE inhibitors are given mostly to reduce the myocardial the remodeling, the LVH remodeling that happens, because that is thought to be improving the diastolic dysfunction as well as overall longevity. Other than that, there is nothing else that we can do medically right now.
Thank you.
Yeah, I believe there are no more questions or comments, no raised hands. I think we are 10 minutes past 8. I think we can close the session, Anoop.
Yes, please.
Yeah, thank you everyone for participating in today's discussion. We'll see you again next Wednesday. If there are any questions or comments or anything that we want to further discuss or any topics that you would suggest, you please post it in the Weekly Huddle WhatsApp group. Thank you for joining us today and good night, everyone. We'll close the session for now.